Is member Teachout back?
Yes, I'm here.
Great. All right. And Dr. Merman, are you here? All right. And CVMC, should I be turning this over once we start to Mr. Cossack?
Chair Foster, I believe Jim Alvarez is going to start the conversation and lead the conversation.
Yeah,
Great,
correct.
thank
Sorry,
you.
I was dropping my mic on. Yes.
Okay, great. All right, so I'll go on the record in a minute, and I'll ask our counsel to swear in all the witnesses. Jessica, if you're ready, we can go back on the record.
Back on the record.
We'll resume our hearing of August 5th. Next, we have the budget presentation and board questions for the Central Vermont Medical Center. Mr. Alvarez is here and Mr. Cossack, and I will ask our counsel, Ms. Korlman, to swear in the witnesses.
All right, thank you very much, Chair Foster. So when we do the oath, if everyone could please, I'll administer the oath, and then as you go through and affirm, if everyone could please go one at a time and state your name as you do. So do you solemnly affirm that the evidence you shall give relative to the cause now under consideration shall be the whole truth and nothing but the truth under the pains and penalty of perjury?
James Alvarez, I do.
Kim Patnode, I do, and I apologize, I'm not on camera. I haven't been given permission to come on camera yet.
Steve Leffler, I do.
Ramsey Harrington, I do.
Rick Vincent, I do.
Bradley Crumpf, I do.
Jennifer Gagnon, I do.
Okay, great. And I'll just note for the record that Dr. Merman is recused from the CVMC hearing, so there'll just be 4 board members. And Mr. Alvarez, I'll turn it to you. Thank you all for being here.
Thank you. You have the slide deck up. Good afternoon, Chair Foster, members of the board. Thank you for the opportunity to share the story behind our numbers and connect this budget to our mission, central to our community caring for a lifetime. I'm Jim Alvarez. I'm the interim president and chief operating officer of Central Vermont Medical Center. Joining me is Kim Patno, our chief financial officer, who will walk us through the financial details. I also want to introduce Mark Kozak, who has been selected after a national search to be our next president and chief operating officer. Mark is onboarding now and listening in today. And Mark, I don't know if you want to say
Sure.
introduction. Yeah.
Sure. Thank you. And good afternoon, Chair Foster and members of the board. Thank you for the time in this busy agenda just to allow me a minute or two to introduce myself. As Jim said, I am Mark Kozak. I am now just 2.5 weeks into my new role here at Central Vermont Medical Center, and I'm very excited to be here. I'm coming to Vermont from the Yale Health System in Connecticut, where I spent the last 5 years as the chief operating officer of Greenwich Hospital in southwestern Fairfield County. Vermont is not new to me or my family. We spent many years visiting, enjoying the outdoors here and winter ski trips. And my daughter Caroline is a rising junior at UVM, studying to be a speech pathologist. And it's great to be close to her. And my wife and I are excited to now call Vermont home. I'm spending the start of my time here, listening and learning, forging relationships with members of the Central Vermont team and the UVM health teams and the community at large. These are relationships that I know will be necessary to build on the work that's already been accomplished and planned for the future. In my first 2 weeks, I have found a highly engaged team who are proud of the work they do each day to care for the patients in our community here in Central Vermont. I look forward to contributing to the work of this board and the UVM Health and Central Vermont teams to promote affordable, high quality, safe care and an extraordinary experience for our patients and teams. So with that, I'll turn it back to Jim and Kim for our presentation. Thank you.
Thank you, Mark. I, for one, am very glad to have you on board. I will continue serving as the interim a little while longer as we transition the organization to Mark's capable hands. I want to start by acknowledging the importance of this board's work on affordability. We recognize that cost is an access issue. When families cannot afford care, that care is not truly available to them. Access to care is why our hospital exists. We're working to solve the same problem for the same people, guided by two aligned missions. And that is the focus of our ongoing improvement work at CVMC and the spirit that our 2027 budget was built on. Our filing aligns with your guidance on revenue. However, it does not align with your expense guidance, and that's the story we'll tell today. Next slide. 2026 is another difficult year financially for CVMC. The important story is that we did not charge more for care. In fact, our commercial rates declined, consistent with the board's expectations. Revenue increased because we cared for more patients, provided more services locally, and accepted transfers when CVMC was the right place for care. At the same time, we face significant cost pressures, particularly in pharmaceuticals. Like hospitals across Vermont and this country, we are seeing medication costs, especially for cancer therapies, rise faster than we can absorb them. As a result, we expect to finish the year with a significant operating loss. My summary of 2026 is demand remains strong, access remains essential, and financial challenges facing community hospitals are real. Our 2027 budget reflects a disciplined effort to improve our financial performance while preserving access to care. Our budget's lower commercial rates in line with the board's affordability guidance. It also reflects the realities we face: pharmaceutical inflation, the cost of maintaining an aging facility, and reimbursements that do not always keep up with the pace of cost of care. We're not standing still. The team across the organization have reduced cost, improved efficiency, strengthened operations, and we are also implementing the Alvarez-Marsala recommendations and other initiatives to improve productivity and support our long-term sustainability. As a result, the 2027 budget improves on 26, but still projects a loss. I will save my remarks for CVMC's long-term sustainability for the end, but for now, I will say this budget preserves access to care in Central Vermont. We are not proposing to close, move, reduce, or transfer services elsewhere. The people of Central Vermont will continue to receive their care in their community. Our challenge is to improve sustainability while keeping that commitment. Next slide. Central Vermont Medical Center has a rich history in the community, and that story does not get told often. The story behind CVMC is a 122-year-old promise. It began in 1904 when the community of Barrie came together and decided they needed to build a hospital to ensure there would be local healthcare for their community. By the 1960s, that promise was in trouble. 3 hospitals carried it: Barrie City Hospital, Heaton House, and Mayo Memorial. Everyone could see they were struggling. In 1961, the medical staff of the 3 hospitals voted to share privileges. And by 1963, Central Vermont Medical Center was incorporated. By August of 1968, a new hospital stood in Berlin, built on the community's resolve not to break the promise. Their promise has become our mission, central to our community caring for a lifetime. For nearly 6 decades, we have kept the promise they've made. Keeping the promise has meant that we are there for when our patients need us. 28,000 emergency visits a year, 160,000 outpatient treatments, 3,000 surgeries, a cancer center, an aquatic center, a skilled nursing facility, and 25 medical and physical therapy practices stretched across the communities we serve. Keeping the promise today has meant this hospital stands as the 3rd largest in Vermont. We employ 1,400 of our neighbors who come together every day to keep the promise. We're the largest employer in Washington County, 1,400 families who have created their lives here, who carry the economy of Central Vermont communities. Being the largest also leaves CVMC in a precarious position. We're a bellwether hospital, too large to qualify for critical access support that helps smaller communities preserve local care, yet too small to absorb the pressures coming from every direction. That is the challenge I'll return to in my closing remarks. Next slide. Our leadership team has changed, but our corporate structure has not. CVMC remains a partner hospital of UVM Health, and Woodbridge Skilled Nursing Facility continues to operate under our tax ID. As I mentioned, Mark Kozak is our new President and Chief Operating Officer. Our Chief Medical Officer role has been filled in an interim basis since December, and the search will resume as Mark comes on board. Our Vice President of Clinical Operations is departing. We will not fill that role. This is a deliberate decision to reduce the size of the leadership team and broaden accountability amongst the remaining leaders. Our Chief Financial Officer and Chief Nursing Officer remain in place. On service lines, nothing closed, moved, or shrunk. 2 planned changes were completed. The Mad River Berlin Family Medicine consolidation that began in 2024 was finished in October 2025. We also continue to provide project support for the Mental Health Urgent Care Initiative with Washington County Mental Health Services and the Department of Mental Health. There's been a lot of focus on our clinical productivity in our practice division. I will share this as a high level. I'm sure this will come up more in detail in the question and answers. This chart shows our FY25 clinical productivity as measured to benchmark. Out of the 10 departments reported, 4 fell below the 25th percentile. Orthopedic rehabilitation was the highest performing department, while psychiatry was the lowest. These highlight opportunities to improve provider productivity across several areas of our medical group. When the 2027 budget was developed, we knew that A&M review was underway and chose not to incorporate additional productivity assumptions before seeing those recommendations. We're now implementing those recommendations and monitoring productivity performance in real time. As providers transition to new clinical hours expectations, we continue to track and adjust our projections based on actual performance. Next slide. Another focus in our medical practices is timeliness of new patient visits. This chart shows the percentage of new patient visits completed within 14 days of scheduling compared to the national benchmark. Across our specialty departments, 3 of the 10 are performing at or above the benchmark, where several departments have significant gaps. Improving access is a priority. The A&M recommendations are intended to improve access and throughput. As part of that work, we have implemented a new medical group operating model with dedicated leadership for both primary and specialty care. Those leaders are responsible for implementing the recommendations and improving access performance. And at this point, I'll hand it off to Kim for the details around the finances.
Thank you, Jim. Good afternoon, Chair Foster and members of the board. As Jim noted, I will walk you through the details of the FY26 projections, the drivers of those financial performances, and the basis for our FY27 budget. FY26 is projected, as Jim alluded to be a loss of $10.6 million, where we had budgeted for break even. To summarize, net patient revenues for 2026 are projected to be above budget by about 1%. This does include the $11.7 million reduction that we took to our commercial payers in the FY24 enforcement, and also a larger impact that we had estimated from our Act 55. I'll go into the details a little bit more in further slides. Our other operating revenues have helped offset some of that loss in the net patient revenues, as we had kind of been instructed by the Green Mountain Care Board to look for other ways for revenues. And our 340B is 74% of that $10.3 million that we're seeing in other operating revenues. We also are seeing about 19% in premium and payer incentives tied to our ACO agreement with Pearl Health. Prior years, these adjustments would have been recorded as part of the FPP or One Care Vermont, but we are recording these as other revenues this year, and that started in January of 2026. Labor is projected to be right on budget, which is no easy feat in today's world. However, where we're seeing our challenges is in our non-labor expenses. That is where our challenge has been. You've already heard from my colleagues at UVMC, and unfortunately, you may be hearing this with my colleagues across the state. Pharmaceutical expenses are our drivers and are about $12.4 million, particularly in the chemotherapy arena of our expense variances. This represents about 49% of our total other operating expenses overage. We've also seen an increase in our medical surgical supplies of about $3.7 million. This is related to new technology that is increasing our patient safety. And one of the examples I can give you is our new IV pumps, along with the disposable costs of IV tubing, is definitely much higher than what we had been paying for, nor did we have at the time we did our budget. Lastly, we've also seen an increase in our purchase services, such as anesthesia coverage, when we have to rely on a locum to step in and help us when we're doing our OR performances, as well as new technology changes to make sure we're taking care of our patients and getting very quick answers and responses for people who are looking at cancer with new genetic testing that is being done through the lab. Next slide, please. Act 55 is definitely one area that we had done an estimate very quickly when we were doing 2026 budget. We had estimated about $7.5 million impact to fiscal year 2026. And I believe I also shared this in our enforcement hearing. We're actually seeing that the actual impact is about $9.4 million. So it's about $1.9 million less commercial revenues we're seeing from the impact of Act 55. One of the key factors is the chemotherapy reimbursements. We are currently identifying a growing number of medications where the reimbursements are actually below our acquisition costs. You may ask the question, well, how is that happening? For CVMC, this is amplified because many of the oncology medications are designated as an orphan drug and are excluded from the 340B pricing. We are a DISH or hospital based on sole community hospital, not traditional DISH. So the traditional DISH, not having traditional DISH is what exempts us from having access to 340B pricing for these life-saving drugs. It's also important to recognize that drug acquisition costs do not always include all of the costs to deliver the care from Act 55. For example, beyond the medication itself, there are pharmaceutical pharmacists, nursing, infusion, the clinical support to require safe providers for these therapies that is not always captured in what Act 55 reimbursements have done at 120% of average sale price. The bottom line is, in addition to the reduction in revenues that exceed our original assumptions, exacerbate the financial pressures on one of the most important service lines that is life-saving in many instances. Before I go into discussions of the financial results, it's important to start with some of the demand. And some of the demands, when we compared FY26 actual performance to FY26 budget, you will see as we move into 2027, many of our demands are not going to be exacerbated or growing from our current run rate. But when we look at it from budget to budget, it may appear a larger growth. We are seeing less inpatients, procedural and elective surgeries that are traditionally supporting the hospital financials that are below budget. We are seeing that both FY26 and FY27 budgets are going to be impacted by this. As we discussed during our enforcement hearings, these are not services that we actively or generate a demand for. These are volumes that reflect patients' needs in our communities. Many originate, as we noted, through our emergency department or are ordered to support diagnostic and treatment decisions elsewhere in the healthcare system. Next slide. You can scoot ahead one more. Thank you. As Jim noted, we built the FY27 around 3 priorities: maintaining access, managing cost, and improving quality while working to meet the benchmarks the Green Mountain Care Board has established. This slide shows where we landed. We aligned with 2 of the 3 of these benchmarks. Commercial reimbursements will be reduced by 1%, and our commercial net revenues will also be reduced by 1%. Where we are not able to align, and this has a large impact with what our current run rate is, we are expecting an 8.6% growth from budget to budget. But if we look at where we're landing for projection, it's about a 1% increase, but it certainly does not fit in the 2.4% guidelines. We recognize that this gap explanation requires an explanation. The increase is not driven by expansion or new discretionary spending. It reflects the reality of rising pharmaceutical costs, inflationary pressures, and investments needed to maintain our building, which is almost 60 years old, expanding access, and making sure we continue our quality journey for our patients. The next few slides, we're going to break down those drivers and explain some of the expense growth and how we built this budget. To start with, I'm kind of giving you the punchline before we go into the details, but this slide shows the FY27 budget before we get to the underlying drivers. We are submitting a budget that is a $3.3 million loss. It is an improvement of where we anticipate to be our projection for 2026, but we still have a long way to go. At the same time, our cost structures, from even having our reimbursements reduced, our cost structures reflect today's pressures: pharmaceuticals, supplies, labor, and overall costs continue to rise. Even with these constraints, the FY27 improves operating performance by about $6.5 million, which is a recovery of about $10.6 million in revenues, and also serving and keeping our non-late salary expenses flat to the FY26 run rate. As we move through the next several slides, I'll break down the assumptions that we use to build our budget. Next slide, please. As with always, and I always like to do it how my mind works when I'm building the budget, we start with volumes. We also analyze what changes from those volumes from our current run rate or even from our prior year budget. So we're looking at recruitment plans for physicians. We're also looking at retirements. We're looking at any access initiatives or expanded demands before we load these volumes into our models for our net revenue calculations. You'll notice that most of the services are fairly flat, but that's because we kept it to our run rate instead of backing it down to our budget to budget explanation. Simply put, we're not treating FY26 depressed volumes for inpatient and surgical volumes as the new norm. We know we've had some changes that we did not anticipate in the 26 year, but we are going to be working to regain those and get them back to the FY26 budget levels. Next slide. Once the volume assumptions are established, we calculate gross charges, which we only adjust gross charges minimally. And keep in mind, I have Woodridge Nursing Home in this space, so typically we do have to increase our gross charges so we do not leave money on the table for our nursing home. We run them through our reimbursement models using approximately about an 18-month historical experience and any known changes in the reimbursement landscape. For example, OneCare Vermont ended its services with us in December of 2026. Most of that fixed payment perspective payments move from that fixed line back to fee for service. For commercial payers, we also model in what our Green Mountain Care Board guidelines are. That's where we reduced our 1% rate reduction benchmark. It's important to note that the FY27 is being built on several reimbursement reductions. Unlike when we had our mid-year rate reduction, which was a temporary reduction, the $11.7 million that we put into our budget for 2026 is permanent, and that will have kept our $11.7 million suppressed for fiscal year 2027. We also have the actual impact of Act 55 running through our numbers now. Our budget doesn't quite include the $1.1 million that we received from the FY25 enforcement adjustment, which will then further reduce our commercial rates even lower. On average, a commercial 1% adjustment is about $980,000 for CVMC. Once we make all of these adjustments, rolling in the $1.1 million reduction from the FY25 enforcement, we will be back to about fiscal year 22 commercial rates. Medicaid, we are assuming no increases or no changes from current rates. And Medicare, well, we have just barely gotten the final rulings for inpatient and outpatient. We are not seeing huge changes from what we had estimated in our budget, with a minus 9.9% in inpatient and a 3.7% increase in our outpatient reimbursements. We are staying flat for our physicians and our skilled nursing center. We are 62% Medicaid in our skilled nursing facility. Next slide, please. Payer mix is also something we look at when we're building our models. For the most part, our payer mix is staying flat. For fiscal year 2027, approximately 65% of our gross revenues and our major commercials are declining about 24.5%. These graphs are actually summarized, and this is some of our realities. 2/3 of our net patient revenues are coming from government programs where reimbursement rates are set for us, not negotiated by us. That limits our ability to offset rising costs through revenues and makes expense management even more critical in terms for our long-term sustainability. Next slide. Uncompensated care is something that we are watching very closely due to some of the changes with the federal government, with people losing access to discounts to their insurance premiums, as well as the increased challenges for Medicaid recipients to receive Medicaid benefits. We are watching this very closely to make sure that access to care is not limited by being able to pay. We have not seen large dollars increased in our uncompensated care, but we are watching it very closely. I also want to summarize this slide because I know this is always something that we hear and see oftentimes. We don't submit any bad debts to collection agencies or credit agencies, so it should not affect someone trying to buy a house or buy a car. And I know that has always been an interesting conversation at my family's dinner table. Next slide, please. I want to pause on the 340B pharmacy. This is one of the areas that is a bridge that helps CVMC to be able to absorb some of the expenses in today's day and age when our net revenues are declining. What I've broken down on this slide is to show you what we are getting gross to offset the net and what our net margin is that shows up in our other operating revenues. This is not a guaranteed revenue stream. Matter of fact, before we came on, I was reading a Becker's article about what CMS is proposing to make changes for 340B. This is not a guaranteed service line. It is a bridge to help us be able to continue to operate and stay viable to help our community members. Next slide, please. So the expense drivers for 2027, which is really our story and our challenge. What I've done on this slide is I've broken it down a little bit differently. The light green bar, if the colors have come through for you, is the actual inflation that we had loaded into our budget based on what we are seeing from the February numbers when we're looking out for forecasting. And the dark green is the dollar amount or the percentages that are tied to either volume growth or actually what we're paying for the items that we're purchasing. This analysis does compare the FY27 budget to FY26, which is where that 8.6% expense growth is coming. However, when you compare it to the FY26 projected actual, it's about 1%. In FY27, as within 26, the largest driver continues to be pharmaceuticals, which is about 54% above our inflation assumptions. One of the significant drivers in our medical and surgical supplies we continue to pursue is to reduce waste and utilization. We have teams that are eagerly going through our inventory and our practices to make sure we are reducing costs and being the most efficient and safe organization. We are seeing increased costs in our purchase services related to lab testing and anesthesia coverage. We are also seeing expenses related to operating and preserving our nearly 60-year-old facility. Jim and I often joke, 58 years old isn't so bad as a human, but our building is not quite so good now. One drug line is most of our drugs, and I wanted to give some time to this. In fiscal year 26, we began separating chemotherapy from the rest of our pharmaceutical expenses because we started to see a significant growth. And when we had it combined, it was kind of murky and buried. So we separated it in 2026. The FY26 budget, however, of $25.1 million is inclusive of the chemotherapy and non-chemo drugs. We broke it about in 2026, chemo is its own separate line. In 27, it is also its own separate line. An obvious question you may be thinking as you're looking at these is, well, what's driving this chemotherapy treatment? Is it more treatments? Are you doing more? The answer is actually no. Chemotherapy is about 40% of our total drug expense and 24% of our total non-salary expenses. But the treatment is not in the volumes. In fact, over the last 2 years, the total doses have declined by 12%. Again, changing technology, changing methodologies, making sure we're taking care of our patients, which changes the cost of the drugs by themselves. On average, when we are buying the drugs for chemotherapy, they have increased about 46% per dose. So what we were paying from $57 per dose is now $83 per dose. That's a pretty big jump in 2 years' time. This is a cost and mix issue. It's not a utilization issue. These medications are prescribed by our oncologist and are provided to our patients so that they can remain closest to their home as part of our mission. We continue to work with our UVM health system, which is a benefit of us being part of the system, to identify opportunities to deliver care in the most effective setting possible, and where appropriate, we have moved high-cost therapies to locations within the system to be a lower cost to our patients and to our partners who are commercial payers. Moving on, travelers. Now, I know last year we had presented a pretty large reduction in travelers, and I was asked last year, do you think those reductions are realistic? I suspect this question will come up again. The reality is, what gives us confidence is the workforce environment has improved. We are seeing many more applications for permanent positions. We have successfully onboarded 9 new graduate nurses, and the retention continues to improve through better staffing, career development opportunities, and competitive salaries. CVMC was the pioneer of workforce development program, and we are starting to see the benefits of this program that we started back in 2018, I believe. The result is that we're increasing staffing this hospital with our own employees who live in our own community. They're our neighbors, and that rather than relying on temporary labor, which has been great at the time, but what we want is people who are here permanently, because that's what improves quality of care, strengthens our workforce, and reduces our costs overall. You're probably wondering, how did we go from 10.6 million to 3.3 million? We had some hard lifts and hard decisions to be made during this fiscal year. This slide summarizes by category the changes that we've made to reduce costs. This is a work in progress, and I'm happy to report I believe CVMC is very strong in our lean efforts, and we never turn it off. Next slide. We also would be remiss not to include what our medical group partners are doing as well. You will see, and you've probably seen this slide a couple times already, so I apologize for the redundancy. CVMC is slated for about $516,000 for savings based on the A&M reporting. This obviously is probably on the low side, but we also are at the beginning stages of implementing all the changes from A&M, and we did not want to be over aggressive and accept larger reductions in our expenses than what we could easily achieve. And I'd be remiss, and when I look at these slides, I kind of always look at operating margin plus days cash on hand equals what we're able to invest in our buildings. But as you can see, we've had a history of not being a successful bottom line. That is our slides on the upper left-hand corner. Our days cash on hand, while these numbers are not exactly lined up with what our Green Mountain Care Board staff members showed on Monday, directionally they are correct. I believe when I calculated this, I had taken some monies out as restricted, and I shouldn't have, but materially not significant. The reality is that our days cash in hand is dwindling. We don't have a large reserve. And then without these cash reserves, what we're not being able to do is that 1968's building that needs a little more than just duct tape and Band-Aids is growing as in beyond average life expectancy. We're expecting to be about 20 years old this year. We have risks that are built into our budget, and that's what I'm going to close with. These are not hypothetical risks. They are the risks that we are actively managing every day, and they highlight how narrow and how fragile our margin for error is in the 27 budget. You'll see under the reimbursement sector, and I believe, again, my colleague Judy talked about it. At the time we put this presentation together, the CMS rules were not finalized for outpatients. They are now, and very quickly, no material changes for us. Our 340B program is always at risk. We are actually on the lower side of the sole community hospital status for DISH, which means we have to maintain 8% of Medicaid inpatient days as part of our total percent of total patient days. This risk for us, for CVMC, and this is just the contract labor or the contract revenue piece, ranges anywhere from 18 million to 23 million. This doesn't account for any of the non-chemotherapy drugs that we're purchasing through our expenses for patients who run through and are impacted by the Act 55. That's about an additional $1 million will be increasing our pharmaceutical expenses in our operating budget. We have our community members that we're very aware of losing coverage because they had to choose between, do I pay for more for insurance premium, or do I go without and roll the dice? Or worse yet, do I also try and do a higher deductible plan and pray that I don't have to show up at the hospital? We've seen a huge drop in our Medicaid population. We actively are going out to where our patients are, soup kitchens, etc., to meet with our members of our community members to make sure that because they haven't signed up for Medicaid, they're not avoiding care, because the longer people avoid care, it means they're going to be even sicker. Inflation costs are always an interesting conversation depending on what tariffs are going to be put into place or not put into place. Our cancer drug prices are very volatile in the market, and we also will be starting our first union renegotiation for our RNs and professional technicals in the 2027 year. I'm going to close it over now to Jim for any closing. Thank you.
Thank you, Kim. Thank you, Kim. To close, I'd like to talk about our commitment to community sustainability in the 122-year promise. And I'm going to start with explaining why the promise is personal to me. I've spent 30 years working in rural healthcare. I've been in leadership positions across 9 health systems from one side of this country to another. I chose Central Vermont as my final home because what matters most to me, being close to the community we serve and seeing our mission come to life. Many of us in this hearing have a personal story about healthcare has shaped their families. I'd like to tell you mine. Some of the best moments of my life have been connected to healthcare. My children were born in hospitals, the greatest moments of my life. I also lost my mother in ICU, my father in an emergency department. I lost my son in the back of an ambulance. The hospital is just simply too far away. I lost all 3 despite the heroic efforts the caregivers tried to change the outcome. I understand deeply what our patients and families go through when they trust us with their care. What we do is meaningful work and can not always be measured with math alone. That is why I care so deeply about CVMC's long-term sustainability. Our filing shows the direction. Negative margins, declining cash, lower inpatient demand, diagnostic needs, cost rising, the pressure of as serving as the bellwether hospital. UVM Health has been our backstop. But as the network works to reduce system-wide costs, that backstop is thinning. Bending the cost curve means matching our community needs with modern delivery care, transforming where we can, shifting where we must. Our lean management system here at CVMC supports that work. Many of our leaders, including our incoming president, are lean trained. Our director of quality and I are both Lean Six Sigma black belts. Our department level improvement boards are in place across the organization. This discipline has helped our teams reduce cost and improve quality this past year, and we continue to strengthen the system. But we also must confront the future of a 1968 facility as it nears the end of its useful life. But this is not about a building. It's about a 122-year promise. When that promise was at risk in the 60s, the community asked what healthcare needed to become next. They planned for a generation, not for a year. Their answer fit their time. I'm not suggesting it is ours. I am asking that we borrow their courage. So to close, I ask that you approve our budgets as filed. Our filing aligns with the board's commercial benchmarks. Our expense growth is real. And driven by our commitment to our promise keepers, the drugs our patients require, and the cost of maintaining a building that opened in 1968. This budget preserves access and keeps care close to home. I also look forward to working together on shaping the future of healthcare in Central Vermont and keeping the promise. Thank you. We're glad to take your questions.
Mr. Alvarez and Ms. Patno, thank you very, very much for that presentation. It was very thoughtful and heartfelt, and we appreciate it. It also highlights just the structural changes and challenges that we are all dealing with without very many, actually with no silver bullets and with limited options. So thanks for understanding that challenge and for walking us through those from your perspective. I'll open up to the board for questions. We'll start with member Teachout and then member Holmes.
Great, thank you very much for your presentation, and I do have a few questions. I was first focused on, and I can't remember the slide number, but the one where you show the 1% decrease. And do you plan, and you said you were going to do it across inpatient, outpatient, professional, and SNF. Is this a charge master reduction that you're contemplating?
You're talking about the 1% reduction in commercial reimbursements.
Correct.
I am going to be honest with you. I don't believe that it's going to be across the board that we will be doing specific charges. But I can get back to you on the details of that if you would like. I don't do the charge master, that's why.
Okay. I think it would be helpful for you to get back to me on that. My next question was on page 13 of your narrative. You talked about outsourcing your lab testing and anesthesia services. Where do you outsource those services?
Our anesthesia services are actually UVM Health, so they're not completely outsourced. They're within the system. And our lab tests, we do have several vendors that we send our tests out to, and I am drawing a blank right off the top of my head of who they are, but I can get those for you as well.
Okay, and do you bill your patients directly for those services that you've outsourced, or does the outsourced entity bill the patient?
For the lab services, when we send the test out, we absorb the price of what we're paying and we add it to the patient's bill. So they're not getting a separate bill from, say, Mayo Clinic. I'm making this up. For anesthesia services, the provider bill for anesthesia would be coming from UVMC, and the surgical case would be coming from for the facility where we do the procedure is coming from us, the CVMC.
Thank you, that's helpful. And so then is the anesthesia price the price that UVMC charges, or the price that is on the CVMC, contracts?
It's going to be the UVMC price, but to clarify how we've done this, and I've done this in another organization, it's called the hold harmless arrangement. So CVMC employs the physician, CVMC will bill for that service. Where we offset and supplement is, as we call it, it's a hold harmless. We pay for the difference between what the physician or the provider, because sometimes it's a CRNA, is paid versus what is collected. So it's the delta between what is not reimbursed by an insurance. Does that make sense?
I think so. So how does that affect your finances?
That's where you're seeing in our purchase services, our growth, and where we see the biggest hit when we have to rely on a locum service to come in and help us fill that void.
Okay. And maybe I'll send a follow-up question, but I guess I'm confused by how this relationship would be different with your affiliation with UVMMC than using the medical group services, the providers that are employed by the medical group.
Can you ask that question again? I'm not quite sure I'm following to be able to.
Let me write it down
answer.
let me write it down as a follow-up, because and this is one that I think I need to think about a little bit more. So it seems to me that you are proposing commercial rate reductions to meet the board's 1% change in guidance for commercial. And I believe, but I'd like to hear from you, that CVMC also underestimated the impact of Act 55. And I'm wondering also if the CT and radiation oncology code changes that Medicare did impact your facility.
They did as well. Not to the same magnitude, obviously, because they're not the same volumes, but they have impacted us as well. I don't have those right in front of me, but I can get those for you. I think I have it in an email somewhere.
Okay, but both of those changes impacted your facility as well. But you're not planning on offsetting the 1% reduction in commercial revenue with those changes?
Not at this time, no.
Okay, Thank you. I appreciate that. And then I'd like to ask you a couple questions, and I don't think it was in anything you gave us about your employee health expenses. I believe that, and maybe it's the whole system, but you changed the way that you pay for employee health care to your own facility. Is that true?
Not in this year. What changed this year, remember, teach out is the administrator who is managing our employee health, our employee pharmacy and our employee health care claims. We transitioned from Blue Cross Blue Shield South Carolina to Cigna. And that started in January.
Okay. And then as part of that change, did you switch from paying for your own employees' health expenses at your own facility as a reference-based price to Medicare to some other methodology?
I am not aware of the details of that change, so I would have to get, I would have to reach out to my partner who negotiates these rates.
Okay, I'll ask and follow up, no problem.
Thank you.
Let's see. And then just big picture, how has the hospital used its capital reserves? You've noted in the last few years, you've had to use them in order to pay for expenses that weren't covered by your revenue.
Well, can I clarify capital reserves because we don't use capital to pay for operational?
Please.
We use
Yes,
capital
please
to
do.
pay for capital. So we
Okay.
don't have huge capital allocations because we get our allocations based on how our performance is. But our cash has been dwindling as we're paying for operations in the last couple of years. One of the things it's been a good thing is we stabilized our workforce with some of our union contracts. So we have a much more competitive wage that we're paying and attracting, and that hopefully is translating to our retention rates. Then those reserves, there's not really a lot of reserves left because CVMC never had large reserves, is also paying for the operation expenses. For example, we had a flood this past year in our Waterbury clinic. It was about $230,000, $240,000 to fix. That was not anything that we would applied for our insurance to cover because it would have been under the deductible. So we were paying for that out of operations, which would have then also come for any money I could have put aside for capital improvements.
Okay. I think I asked that incorrectly. And then I guess the last question I have for you is, you're a separate hospital, but part of the UVM Health Network. You manage a large number of things independently and then depend on the network for other support and services. In balance, has that relationship helped your hospital financially?
That's a great question, member teach out. I would have to tell you some of the talent that I have access to from the system for some of even the work I do, whether it's cost reporting, whether it's contract negotiations, whether it's contracting for supply chain, we would not be as successful without having that partnership with UVM Health. Standalone hospitals have a very difficult time in today's environment because with size comes buying purchase power. And I don't think we would be alone without having the partnership of UVM Health there to help us.
Great, thank you. And as part of that, when you're purchasing things, do you have to purchase the same supplies that the whole network is purchasing if there's options? Or are you able to independently pick different items or vendors or contracts if they benefit your hospital more?
within the lines of our group purchasing organization or that we belong to, the GPO for drugs as well as supplies. We do have choices of vendors because sometimes vendors cannot carry everything. We've had several times in the past couple years where a vendor we've relied on, for example, the saline, I believe it was in North Carolina when they had the flood, we had to scramble. So if we'd been locked into one vendor, we would have been in very dire straits to take care of our patients. We were able to switch very quickly, but we also had that expertise from supply chain that could help us navigate who else is out there for the next lowest cost and high quality of our products we need to take care of our patients.
Great, thank you. That's really helpful. Those are all the questions I had for today, so I'll pass it along.
Thank you, Member
Thank you.
Teachout.
Member Holmes?
Yeah, thank you. Thanks to the team. Mr. Alvarez, how are you doing today?
Good. How are you?
Good. You've stepped in this role,
Yes.
as interim, and I'm sure your colleagues and community must be, really grateful for that. Often, a fresh set of eyes, a new perspective can uncover some blind spots or some potential undiscovered opportunities, just coming in for the first time and seeing it from a new perspective. So I'm wondering if you can share any blind spots, undiscovered opportunities that stood out to you in your tenure so far that might positively impact health outcomes and affordability for the CVMC community.
Yeah, thank you. I've been with Central Vermont for 8 years. I think there's been one 8-month period where I only had one job. I tend to do my day job and a bunch of interims. And so this has continued that trend. I think that the biggest thing for me is my coming in as the interim president aligned with a lot of work around what we were doing about affordability and, at a system level. And it also aligned with work we've been doing here locally of building the foundation of lean. And so we really accelerated our operating systems output, I'd say, in the last 4 or 5 months. And it's not that we weren't going to do it anyways. It just kind of created this burning platform, but it energized the organization. And we went into much deeper analytics. And we were seeing a supply cost problem, but we went back to 2022 and had the system run us everything that we purchased in 2022 down to the pack size and the cost for every department in the hospital. And we found there was 1,051 items that we bought this year that we had never purchased before. And that was the shifting delivery of care, right? So we're shifting in how we do stuff. We got new IV pumps that required new tubing. There was changes in how we took care of care. But I think that what the work is going on right now is did we wind down the previous item as the new one came in? And so that was all energized work. And we are on what's called a 2-bid lean system in our storerooms here. So it's really easy for us to identify if there's not movement there. And so I think that coming in was really a chance to bring the organization together and say, look, we've got all this foundation in. Let's take this out in for a drive. Let's see what results we get from it. We've also kind of restructured our leadership team where we used to have a senior team meeting. It was just a small 5 or 8 of us every Tuesday, and the director meeting once a month. Now all the directors are in the senior team meeting. And so we have an operational meeting every week, which is allowing us to move faster. And we've moved all the managers into the meeting that the directors used to sit in. And so we're really kind of changing the organization to respond faster to what we need to do.
Great, that's really helpful. Sounds like your black belt is coming in handy here.
Yeah.
Looking back at the Mad River and Berlin family
Yeah.
medicine practice consolidation, and you may or may not be the right person to answer this, but maybe you or somebody on your team, but it was completed last fall,
Yes.
and I wonder if, a type of after action type review might be
Yeah.
applied to this. The decision
Yeah.
to close the primary care practice was a difficult one for a lot of people to understand, including myself.
Right.
So now that some time has passed from that decision, what does the look back reveal about the costs and benefits of that, consolidation, the consequences intended or unintended for the communities that the Mad River practice
Right.
served? Honest
Right.
lessons learned.
Yeah, I'll probably pass that to Brad pretty rapidly. But
fair.
from my travels out in the community, I'm not hearing that it actually impacted their access to care that was originally a concern when it first happened. I think that the Waterbury Clinic is servicing those folks in the Med very, very well. But I'll let Brad kind of address the cost benefits analysis.
Yeah, in summary, the cost benefit we did at the beginning, we basically affirmed was accurate. And if you recall, it was mostly around the unit cost and trying to find scale. I think if I'm hearing you right, Member Holmes, what's under the question, at least in my personal experience, is really important, especially as somebody that went down to Mad River with Anna Noonan pretty regularly. So, Jim's point, I think, is probably better taken in terms of, what the feedback in the community is. But I also think one of my personal learnings, I think, was when physicians really chose different employment and specifically to be in a different model. And I think that's going to have some potential for the state as well. So when they went into more of a boutique model.
Yeah, can you talk a little bit more about that? What the transition was and how that's, just a little bit more about the boutique model that you've seen them go into and how that impacts
Sure.
the
Yeah,
communities.
the one we've seen recently is my understanding is basically a national model that folks can step right into. I think some people call it more like turnkey or plug and play. I think the difference is in terms of what primary care at UVM Health or CVMC offers versus the boutique model are different staffing ratios. And the key difference is really a very different panel size. So the panel sizes are roughly half, and the payer mix is very different because we're talking about folks that, in addition, to their insurance, are paying into it. So I think there's impact. There's pluses and minuses.
Okay, and so are you, given the panel size there and the consolidation, you're not hearing about any access challenges in the Mad River Valley community as a result of these changes in the past year? Is what I'm hearing.
Personally not.
Okay. Thank you. That's helpful. I wanted to talk a bit about basically the turnover rates. So when I look at the turnover rates, they seemed relatively high compared to some of the other hospitals for MD, CNA, and LNA nurses even. I'm looking at the table right now. It looks like your RN turnover rate from 24 to 25 to 26 is increasing. The CNA and LNA annual turnover rate in 2025 was 60%, which seems really high and high relative to previous years where it had been between 30 and 40%. Even the MD turnover rate in the last couple of years has been between 7 and 13%, which is high relative to the other hospitals. And so I wonder if you could talk a bit about what's driving what appears to me as high turnover rates and how those turnover rates relate to morale in the hospital and your ability to recruit, retain workforce, as we heard a little bit about in the presentation today, and particularly reducing your reliance on travelers. When I look at the turnover rates, I worry about your ability to reduce your reliance on travelers. So can you talk a bit about that?
Brad, you want to take the providers and we'll take the staff from there?
Yeah, I was going to hand it to Dr. Harrington if you have anything.
Okay, all right, good.
Yes, first of all, I'll just concede that looking at the physician turnover rate of 11.5, 12.9, 12.7, that's FY21 through 24. I don't have a great answer because I wasn't engaged in that time period. I can tell you, though, that we currently have no locums at CVMC, and it's because even with a high turnover rate, it's been, at least in the last 18 months, relatively easy because of the good practice environment at CVMC. It's a huge draw to pull a physician, particularly a physician that's interested in community practice, plus or minus some element of having learners in the environment into. So why rates were high in 21 through 24. I can't really speak to that.
Okay,
And,
let me ask a follow-up question, actually, just before and I'd love to hear from you too, Mr. Alvarez, about the staffing, but given the changes in productivity that are anticipated and the expectations around productivity increases, is it going to be as easy to recruit into the CVMC environment, given that the expectations are now higher?
I mentioned on Monday that recruitment or retention is a priority for us, and we are anticipating it being more of a challenge to recruit into more clinical hours per FTE. But, most of the national markets have shifted that direction. And so I don't think that we're recruiting from a position that is different than the systems that most folks are operating in right now. And I'm still betting on successful recruitment, even into the increased clinical hours per FTE, because of all the other good things about the job.
Okay, that's helpful. Mr. Alvarez, feel free to add
Kim,
about RNs.
what I don't have is the turnover rate by which area. I know that we've had a lot of turnover rate in our skilled nursing facility, but that's an area that is not unusual. We've also had some turnover around just the struggles around childcare and housing. So we just had one this week that lost their childcare and are actually moving out of the area because they couldn't find childcare for a year. And so I think we can get back to a better answer, because I think I need to look at where did it happen at, and we probably give you a better swipe at that.
That's great. And some of the materials that you did share do break out Woodridge. But any follow-up on that would be helpful. Just because it is 60% seems alarmingly high, even for your own trajectory. And it does factor into the ability to, recruit, retain, and reduce travelers. So
absolutely.
I guess my final question is around the financial penalties on CVMC for readmissions and hospital-acquired conditions that were back in 24 and 25.
Yes.
And in the narrative, you helpfully describe, the steps that are taken to reduce both. And I recognize that the penalties in 24 and 25 go back to 21, 22, or 22, 23. I can't remember the years, but I know that that's, lagged data. And so the data that, we would have access to is lagged, but the data I'm assuming that you all have access to is more real time.
Yes.
And so I'm wondering if you could share, have these steps that you've taken, are you seeing material differences in readmissions and hospital, acquired conditions in a way that you could share some of that updated internal data with us?
Yeah, I'd love to. We've made significant improvements in our quality, and it's probably good just to send you an updated quality dashboard so you can kind of see where we are. But there has been significant improvements around our quality in all areas. So
okay, that would be helpful. I'd really appreciate that. So those are my questions, and thank you so much.
Sure.
Member Walsh, any questions?
Yeah. Good afternoon, everyone. Thanks for being with us. I appreciated how you walked us through the variance from in operating expenses between the budgeted amount, the projected amount. I'm wondering, when you became aware of those and began to understand which were structural, which might be temporary, which might be manageable or unavoidable, did you present any alternatives to the CVMC board for discussion about which path to pursue?
I guess I need a little. Can you frame that question a little different? I'm not sure which. Can you help me to frame the question? Yeah.
Sure. Sure. There's an 8.6% operating expense growth between the budgeted amount for 2026 and the projected amount.
Yeah.
We're being asked in our judgment of the budget to carry that same amount into the 2027 budget.
Yeah.
And what I'm looking to try to find are efforts to reduce that overage so that the entire amount isn't carried into 2027. And I'm wondering if any alternatives were explored, and if those alternatives were brought to the board of your facility, or if they were just managed in-house.
And Kim could jump out of this, but we.
So
it was-
Jim, can I jump in for a second?
Oh,
So-
yeah, absolutely.
Yeah.
Yeah.
So Member Walsh, if it's okay, so I attend the board meetings at every single site across UVM Health, which is 8 different boards, so it's quite busy. The CVMC board was fully involved in the budget process, building the budget, approving the budget. They have a good understanding of where the expenses are. And so different than last year when we presented to CVMC's board, had a budget presentation, voted on the budget, and approved it. So I do believe the board understood why the expense increases were in there and what the impacts would be. I hope that helps.
It does. It does. Thank you.
I will say, what we're seeing, the run rate is so specific to pharmaceuticals, and without getting into too much details about one particular patient, we had one that just that one patient's cost alone was $1.8 million of pharmaceuticals. And so, I mean, our struggles around our costs is just really around one area. We have done a lot of work to lower the cost in other areas, but that pharmaceutical cost is blown past everything we're saving everywhere else.
Yeah. Yeah. We hear that often, and
Yeah.
I understand that it's true, right? I'm not trying to argue about that. I did ask earlier this morning and earlier in the week for more help understanding the net with pharmacy. The costs are very high, growing rapidly. I understand from your presentation that some of the reimbursement doesn't match those costs, but we also see a lot of data that the revenue from the sale of these drugs is quite high. And it would help us assess your budget if we had better understanding of the net.
Yeah.
Member
understand.
Walsh, I just
Yes,
want to
ma'am.
make sure, Member Walsh, I don't mean to interrupt, but I just want to make sure to not combine any contract revenues from our other operating revenue for 340B contract revenue with the care that we're taking care of patients within the walls of our hospitals for the drug costs. What we're saying is in the walls of our care, excluding the contract revenue, that's what we're challenged with, and that's what we're wrestling with, and that's what we're adhering to, the Act 55 reimbursements of 120% above sales price. That is not necessarily going to flow into the contract revenues for 340B. That's different because that would be then in controlling Kinney Drugs, Walgreens, Walmart. I'm trying to think who else is locally here. CVS. That would be controlling what they're charging and reimbursing as well. So it's kind of like not the same. It's still drugs, but it's not reimbursed the same. Does that make sense?
I follow what you're saying. Quite honestly, we're at the edge of my understanding of how the accounting for this works. And that's why I've been asking for more help in understanding what that net is. Because I hear a lot about the cost. I see a lot of revenue, and understanding what remains, even though there are different streams flowing, what remains would be helpful.
Okay, I think I'm following what you're asking for, but I don't have that in front of me. So if you want to provide a follow-up question, we can look to see, but I just want to make sure that we don't combine 340B contract revenues with hospital revenues. It's truly not the same thing. So we can provide this, but it won't be, it's going to be a fruit salad, but it's not going to be apples and apples.
I appreciate you supplying that, and we'll work through it together, our staff.
Okay,
your
thank
staff.
you. Mhm.
You've described, in addition to the pharmacy, a number of significant pressures that really seem to be outside CVMC's control when it comes to operating expenses. I'm wondering, within your environment, where do you believe there is meaningful control and choices over the operating expenses? And what are you trying to do differently as a result?
Yeah, we are very focused on the controllable expenses right now. But I think the real conversation is one that we talk about but haven't made progress, is what is true transformation of where care is given. I mean, there's a quote I use when I'm working on lean projects with people, and I won't be able to attribute to who came up with it, but it's not mine, is that the light bulb was not invented from the continuous improvement of the candle. And so we keep on trying to improve the candle. We've got to invent some light bulbs. And I think that's what we're all struggling with, is how do we keep solvent in the current system, but then make the bold decision about what do we really need to change, right? So what should CVMC be providing? And what should that cost be to the community? And what should go to the medical center? What should stay here? I mean, what should go to Copley or Gifford or Dartmouth? I mean, those are the conversations really going to get us to the answer. But in the meantime, we're just all trying to stay solvent.
Yeah, well, I appreciate that response very much. I'm familiar with the quote, and unfortunately, I can't help you with the origin. It's to get on the spot, right?
Yes, exactly.
And you can't. But I think it's important, and I do appreciate the response. It's important because I think as leaders in a difficult environment, where there are a lot of headwinds, it's our responsibility to find those opportunities.
Yeah.
In the budgets submitted over the my years on the board, there have been quite large variances at times, both in operating expenses, sometimes in revenue. And I'm wondering what you're doing differently to try to understand those variances in the budgeting process, and if you have any processes in place to try to reduce that variance.
Yeah, I think it's, our budgeting process is, interesting. Stan, you probably have heard this. We build budgets so far out, and we're finding how we deliver care evolves so fast. The demographics of Vermont's changing so fast that it's really a struggle to do accurate budgets 18, 24 months out, which is really how long we're going, right? And so what our attempt is to do at CVMC right now is to move away from monthly retrospective budget versus actuals to a rolling 90-day forecast. So we're constantly adjusting to the volume, adjusting staffing, adjusting cost, because I think it came up in our enforcement hearing. We have these wild swings in inpatient census. We have these wild swings in demands. And as a small community hospital, it's not a term that I think I've heard used here, but I've heard it in other systems, which is the wait time ready cost of a rural hospital. So we have a full OB unit. And I'll use this because this comes up a lot. Where last week I think there was 3 days we had 0 patients. Today we got 5 babies being born. The difference between that cost in rural healthcare is the wait ready cost, right? So we have a $10 million MRI or whatever cost. In a different market, that thing would be cranking 2 shifts a day. But it doesn't here because we need it when we need it, but there's a wait ready cost in rural healthcare. And I think that's one of the things that we are trying to adapt to better, is we recognize we have this wait ready cost as a small rural hospital. But writing the budget 24 months out and just sticking to that budget doesn't allow us to adjust faster. So we're actually changing our operating system to try to flex faster.
Member Walsh, I'd also like to add to that. One of the benefits that I have the luxury of having is the modeling system that we use to estimate net patient revenues. If you recall in 2025, because we saw revenues and were running hot in the commercial arena, we came to the Green Mountain Care Board and offered to do a reduction in our commercial rates. So that modeling system, if I was standalone, I wouldn't have that sophistication and ability. And, you know, as Dr. Leffler said, keeping it, while it may be a 1% budget adjustment or, you know, off, and it may be big dollars, to be 1% on budget you built 15 or 16 months ago is pretty amazing. So we have the models, we have the tweaks that we're continuously looking at. Expenses are the ones we get the surprises. The floods that occur in Waterbury. Well, we want to hurry up and get that clinic back on site pretty quickly so we don't leave our patients hanging. So those are the surprises that throw us those curves every now and then. But then we figure out a way, what else can we do to change, you know, get our expenses down. So that's the stuff we work and we do every day. And with Jim's note of how we've changed up our leadership, meeting with our directors weekly instead of monthly has made a huge difference as well, because now the directors are part of the conversation.
I appreciate the context, and Mr. Alvarez, I appreciate you gave a pretty clear answer on one of the changes, right? And the 90-day forecasting and watching the variance and that. And some of the other terms that you used, I'm familiar with. I think as we shift toward focusing more on operating expense management and discipline, reducing the amount of variance becomes more important. And first step in trying to do that is understanding where's the signal, where's the noise, and how do we understand the width of those error bars.
Yeah.
So I appreciate very much what you were describing. I think for what it's worth, I think that you're on the right track.
Well, it's always an interesting conversation. We talk about standardization because the point of standardization is to eliminate variation, but innovation by its very nature is variation. So how do you leave room for innovation while you try to have standardization? So that's always this, you know, what we're working on in our lean work. So.
Yep, very familiar. Your financial recovery plan is dependent on revenue growth. And when I look at that, I'm wondering what the management plan is if those revenues fall short.
Yeah. A conversation we're having a lot right now is really about the decline in inpatient care or inpatient need in this increased demand in diagnostic and procedural. And are we adjusting fast enough that balance of resources? And so we are doing a lot of work with Epic in predicting our inpatient nursing staff on 4-hour increments and adjusting to a predictive model. So we are using that to control cost. But I do think there's a fundamental view of the organization that we really have to confront is that right now we are built around being an inpatient hospital that does the ambulatory. We need to shift to be an ambulatory center that has inpatient beds. And so that's just a fundamental shift of how we lead the organization that I think we've got to confront in the future.
Thank you. I think that's well said. And you see, my worry with the variance and the growth in operating expenses and the hoped for revenue.
Yeah.
Right. This becomes an unsustainable model.
Yep.
And the growth in operating expense when revenue's uncertain becomes the next year a request to regulators for more revenue to cover the operating expense we approved the year before. So somewhere we need to find brakes, a way to pump the brakes on the growth in operating expense if we're ever going to try to get a handle on the revenue.
Yeah, I agree.
earlier this morning, you're part of the health network, and earlier this morning, I asked some questions at the closing on well, I don't feel a need to repeat them as part of the network, and
Yeah.
I think we got the answers earlier. I appreciate your responses, and thank you very much for coming in.
Thank you.
Okay, any questions or comments from the healthcare advocate? Hearing none from the HCA, I'll turn it open to public comment via raise the hand.
Yeah, nothing from us, Chair Foster. It took a while to come off mute. Thanks.
No problem. Thank you. Any public comment? Okay, I see none. So I want to thank everyone for their presentation and responding to the board members' questions. We will take a break until 2:45 when we have Porter scheduled. So we have a short break, and then we'll see the Porter team at 2:45. Thank you very much.
Thank you.
Just checking to see if members Holmes and T-Chat are back.
Yep.
Great.
I am here.
Great.
Also
All right,
here.
Mr. Ortmeyer. See you, it's Tom. Mr. Ortmeyer, do you have everyone you need?
I believe we do. Yes.
Okay. Your audio is rather faint. Try it again.
How's it? How's it now?
I can hear you, but it's faint. Is anyone else having that problem? Yeah.
Okay.
Mr. Camus, why don't you try and we'll see how yours works.
Good afternoon, everybody. How am I sounding?
Yours works well.
How about mine now?
It's
No?
it's doable. I'll just ask the court reporter if she can hear it okay.
I can hear him okay.
Okay. Then we'll go back on the record.
Back on the record.
Right. We will resume our hearing of August 5th. The last hearing of today is the presentation by Porter Hospital on its fiscal year 27 budget. I'll have Ms. Korlman swear in the witnesses, and then Mr. Ortmeyer, the floor is yours after you're all sworn in.
All right. Hi, everybody. So whenever we do the oath, I'm going to administer the oath, and I just ask as everyone affirms the oath, if you could please go one at a time and state your name as you go. So, do you solemnly affirm that the evidence you shall give relative to the cause now under consideration shall be the whole truth and nothing but the truth under the pains and penalty of perjury?
Bob Wertmeyer, I do.
Scott Como, I do.
Steve Leffler, I do.
Ramsey Harrington, I do.
Rick Vincent, I do.
Bradley Crumpf, I do.
Jennifer Gagnon, I do.
Mark Stanislaus, I do.
Okay, thank you, Chair Foster and members of the Green Mountain Care Board. Good afternoon. So I'm Bob Wertmeyer, President for Porter Medical Center and Elizabethtown Community Hospital, New York. Really appreciate the opportunity this afternoon to present this year's budget to the members of the Green Mountain Care Board, along with our CFO, Scott Como. I've been now with the system for 5 years, President for Elizabethtown, and 3 years in my joint role as President for Porter Medical Center. Next slide.
Oh, great. How are you? I'm good. How are you?
So as mentioned by my colleagues before me here, our budget priorities begin with how we meet the needs of our patients within our communities, with a focus on quality, access, and addressing the rising costs of healthcare. Porter is really proud of what we offer the residents of Addison County and the surrounding communities, keeping care as close to home as possible. The budget submitted was approved by the Porter Medical Center Board of Trustees in their June 4th, 2026 meeting. Next slide. So just a few facts to familiarize yourself with Porter. We're located in Middlebury, Vermont, critical access hospital, 25 beds, 98 long-term beds with Helen Porter nursing home, 206,000 encounters, 14,500 ED visits. That number continues to grow as we mention each year. And large employer within the area here, 759 staff, 79 employed providers, and a service area of around 32,000. What's missing here really, too, that I just wanted to mention is that Porter is expecting around 325 births over the course of this next year. So as is the case throughout Vermont and supported by Oliver Wyman, our overall population here is aging, which is no surprise. and declining year over year, along with our working age population declining by 31% over the next 5 years. This not only presents available workforce challenges, but this will also continue to challenge access to specialized services as the population ages, as well as stress the already demand on our long-term care environment. And Porter, we're really fortunate to have Helen Porter here on its campus. Porter began with a stable financial year this current fiscal year, maintaining our compliance with the current budget, but results after January started to trend negative as the results of the inclusion into Act 55. CAUSE have been exempt from this legislation unless attached to a network, and that now includes us here at Porter. This has had a significant impact on our financial performance, requiring some course correction, and the overall impact of that will be covered in detail in a little bit. Next slide. So this has been a very challenging year with all the changes here internally, as well as the many external pressures that healthcare is currently experiencing. There's significant expense challenges, and we have an ongoing review of our processes. It's just ongoing to gain efficiencies where we can, looking at our processes, whether it's a clinical process. An example of that this year that we implemented a new inpatient nursing model, which saved us $1.2 million. Several administrative processes and changes we looked at. And I know Member Merman on Monday, you asked about kind of specific examples around shared services. And if you want to take a microdose look at that with Porter, we put a real particular focus on this over the last 3 years with our administrative services. We've reduced the cost by consolidating and sharing roles, 13 FTEs in total, and primarily leadership roles with Elizabethtown Hospital, which is, again, a critical access hospital, adjacent geography to Addison County. I spoke of this last year, and these efficiencies have continued, and we've added additional shared roles now with shared savings in excess of $2 million annually that get shared between the two hospitals. Our most recent was our chief nursing officer and our infection prevention director. There's many other initiatives underway to address our expense reductions with positive results that Scott will cover momentarily. Benefiting from being part of a larger system, and member Teach Out, I know you just asked this question to CVMC, what's the benefit of that larger system? Well, for us, there's many, but one I want to call out is successful recruiting. We've had another good year of recruiting here for Porter. We benefit greatly because providers join the larger system. We get pieces of those FTEs to help support the services here at Addison County. This includes new providers in primary care this year, OB. We have a cardiology fellow that hopefully will stay following completion of his training. Hospitalists, new podiatrist starting in the fall, emergency medicine physicians, GI physicians starting over the course of the winter, and an OB psychologist and several advanced practitioners in several key areas where there's need. So in addition to this, we continue to offer the e-consults to reduce that need for an in-person specialist appointment to keep that care here still local. And all this obviously is around access in our community. Meeting the ongoing needs of the patients with the appropriate facilities always is a challenge. As we experience the capital constraints that you've heard about from others. We are completing our construction at Pond Lane this year, in October. This combines new orthopedic, rehabilitation, and podiatry practice. It's bringing those three together. We're able to gain, we're able to gain operational efficiencies there by combining these practices for some cost savings. And our planning continues around an appropriately sized emergency department. The current ED is severely undersized, as I've mentioned before, with our annual visits continuing to grow. Philanthropic initiatives will play a major role in lifting this project off the ground when it's ready to go. Our work in the post-acute area begins on day one of admission. There's focused initiatives with case management, dedicated utilization management. Again, these are great resources that we can get from being a part of a larger network, which helps Porter facilitate the patient placement at a more appropriate pace, getting those admissions to help partner hospitals with their capacities. Average length of stay for Porter Hospital right now is around 2.8 days. And what helps drive that is our external relationships with Addison County Home Health and Hospice, as well as the counseling services of Addison County that allow patients to get to the right level of care in a more expedited fashion. And although Helen Porter Nursing Facility is not part of the hospital review process, I just want to emphasize again its importance to our community as the sole long-term care facility for Addison County, which is financially supported by Porter Hospital. You heard Steve and others mention around quality, 5 stars in 5 years. That's no different for Porter. From a quality perspective, the current CMS star rating for Porter is 3 stars. During fiscal year 26, our quality department continues to lead our hospital-wide quality, patient safety, and performance improvement efforts. This work, which is lean-based, is supported by a culture of continuous improvement, grounded in daily tiered huddles, transparent performance monitoring through a quality and safety dashboard, and a structured committee that includes Porter board members that promotes accountability, performance oversight, and sustainable improvement across our organization. Performance improvement efforts focus on high-risk, high-volume processes, including our care transitions, med safety, infection prevention, patient experience, and ongoing monitoring of the quality indicators and safety events and patient feedback really support the data-driven decision-making and learning across Porter. Lots of good work is being done by the teams, and we really look forward to the next CMS release in the fall, as we anticipate the scores to be more representative of the good work of the teams over these last 2 years. The next 2 slides, actually very familiar, you've seen these. This is the A&M report as it relates to Porter's opportunity around clinical productivity and timeliness of care in the medical group practices. You've heard about the strategies being employed there. I won't go into that other than to say that Porter is here to support the work of the medical group to see this important work through. So overall, there are really no significant changes in volumes or services provided, but rather we continue to look at how we can do things differently that drive efficiency through increased collaborations locally, regionally, as well as across our system, resulting in increased access to quality care for our communities. So to go into the numbers and the budget further, I'm going to turn it over to Scott Como, our CFO.
Thank you, Bob, and good afternoon, board members. And I appreciate this opportunity to get into our FY27 budget submission in a bit more detail. Next slide, Jay. So as my colleagues did, I will start with how we anticipate to end this fiscal year, FY26. And for Porter Hospital, we expect to end the year with an operating income of approximately $2.1 million, which is against a budgeted income of $10.1 million. The drivers of this bottom line budget miss are largely on the revenue side of the equation, and 9 million of that, to be precise. 3 general buckets. Volumes in our operating room and on our inpatient unit are trending under budget, which is generating less NPR. Act 55, and in addition to Act 55, the lack of budgeted contractual increase from Blue Cross Blue Shield, we should have added that to this bullet, but these 2 items combined are amounting to a commercial rate reimbursement much lower than expected, and we have more detail on that in a future slide. And then third, our 340B contract pharmacy revenue. There's so much complexity within this business, and honestly, I'm glad at Porter we're not a part of most of it. This is unfortunate, but it's much more easy to understand. So We participated in 340B contract pharmacy business as being able to obtain drugs at below market prices. As that 340B market has developed, retail pharmacies don't need to rely on our discounts as they used to. So that business of providing our drugs to them is eroding. And Porter does not have a retail pharmacy of their own to participate in the upside of that swing. So we're seeing an erosion of our just straight up contract pharmacy revenue, which in this current year, we expect to come in about $1.5 million under budget. And we do have a future erosion of that business expected into our budget for FY27 as well. The good news coming into the end of FY26 is we do expect our expenses to overall be $1 million under budget. So the two combined add up to the $8 million gap that we show on the left-hand side of your slide. Next slide, Jay. Okay, setting some context for the details of the FY27 budget. The stacked bars that you see here on the far left, the current year budget. In the middle is our current year projection, and on the far right is the submitted FY27 budget. The green bar represents total revenue. The reddish bar represents total expense, and the gap is the expected income. And so in the gap in the first stack, that represents the $10 million of income we were budgeted to make. The gap in the second stack represents the $2 million of income we expect to actually make. Going into FY27, you can see that it really reflects like a recovery year and largely back to the expectations we had coming into this year. The gain, the $10 million improvement, is really on the revenue side. And you can see our expense base is largely level year over year. So I want to just highlight that the $10 million improvement and the growth in the green bar that you see there is largely volume driven and not rate driven. In fact, we have no change in our commercial rate request. We do have a 3% Medicare cost reimbursement request or rate increase built in. But other than that rate increase, there are no rate increases built into the budget. That revenue increase is largely driven on volume. And as I mentioned earlier, largely recovery to the volumes we were expecting to see this year. The role in the system financial outcomes, really what we're trying to convey there is that we're trying to maximize Porter Hospital as the resource that it is. And again, it speaks to largely getting back to the plan we had in place. This growth that you see in revenue from our current position is not requiring any new investment. It's really based on, again, current expectations that are just not being met, that we have more focus and direction on, I believe, coming into the new year. And within our budget, there is a focus on affordability. So while the revenue is increasing significantly, again, there's no commercial rate increase built in there. And we also have built in a negative 1% gross charge decrease. So we plan to lower our gross charges in a way that is most meaningful to Vermonters. As a critical access hospital, we've participated in the recent discussions about our Medicare beneficiary coinsurance calculation and how that's done and how that is impacted by fee schedules in the state of Vermont. And we want to begin to lean into that in a couple meaningful ways. And one of them is to, start to move the fee schedule. I am happy to report that in my time at Porter, we've done internal and external reviews of our fee schedule. And in a few different ways of looking at it, we are well below 500% of Medicare in our fees, closer to 300%. So I know we're not in a bad place overall, but I know we can do more. And why do we need to push to do as much as we can, as fast as we can? Is we need to restore the trajectory of our days cash on hand. And going back to what Bob was mentioning, we do have a future ED project in our sites. It's long overdue. the need is high, and we're just trying to find a way to it. And while philanthropy will play a big role for sure in making that happen, we want to make sure that we're able to participate as much as we can. So that's why we're putting this together in the way that we are. Okay, so when it comes to the overall like $10 million improvement from where we are now to what we have budgeted, big part of that is on the revenue side. There are some, puts and takes on the expense side of our equation. We obviously have built-in increases happening just like everybody else, but we do have some positive movement on some things, bringing the overall number back down. This is really a summary of the bigger items at play. And the first three all center around that revenue increase. We do have opportunity in our operating room to do more. We know that our volume budget for this year, except for 100 cases, is actually mapped down to individual surgical providers. So I have a high degree of confidence that we know how to execute on the plan that we have in place. We just need to be able to do it. We are seeing a increased run rate in some of our ancillary services, radiology, lab, the emergency department, and there's no expectation that those are going to go away. So just budgeting them at a run rate more than we have now is going to add to our current revenue stream. The next item is probably going to warrant some discussion once I'm done presenting, but it has to do with our infusion service. As modest as it is, prior to Act 55 did generate a modest profit for Porter Hospital, and since the advent of Act 55, it has not. It's turned not profitable, and that is a big driver of the revenue decrease that we talked about that has us missing budget this year. And so we can't continue to operate that infusion service at this level of loss, but we don't have an exact clear way out. We want to continue to serve the number of patients that we see. And so we are going to take a deep dive into what we can do on the expense side to limit the expense side of the business. Now, since we submitted this budget, and as we were preparing for these presentations, I've been informed that we're actually making good progress in really case reviewing the patients that we're seeing at our infusion service, making sure they're getting the right drug, at the right price and the right efficacy. So just, reviewing orders, making sure things are appropriate is starting to make us more efficient. And I hope, and I assume that there's more work to be done there, but this is something we're going to need to keep an eye on over the course of the year, is the trajectory of our infusion service. And lastly, it's just we have another $1.2 million of our 340B contract pharmacy revenue taken out of the budget for next year. That leaves us with about $1 million of business left. As a critical access hospital, I'm not sure of Porter's future in that space, but it is limited to the contracts that we have with local pharmacies. So how does this stack up vis-a-vis the board guidance? From a commercial reimbursement rate perspective, as I'll get into all three of these, our budget contains no change in our commercial reimbursement rate, understanding that the guidance was for a negative 1%. A large driver for that, as we'll get into, is the effective rate decrease that we've recognized in the current year through Act 55 and the lack of 2.9% increase that we budgeted from Blue Cross Blue Shield. We ended that negotiation with 0% increase. So those two things combined have effectively lowered our commercial rate already. Commercial net patient revenue, we are compliant with the guidance of a negative 1% budget year to budget year. Even though we had a reduction in rate and actually commercial is a lower piece of our payer mix, we are budgeting some increased volumes as you'll see and as you saw in the revenue graph. So with those increased volumes does come more commercial business, but overall, budget year to budget year, our commercial net patient revenue is compliant at -1%. On the expense side is where we've made some continued good work. And again, this kind of showed in that first graph that I showed you in that we're a -0.23% budget year to budget year, but largely we're able to keep expenses flat from budget year to budget year through a lot of good work that I'll get into. Next slide, Jay. Okay, so commercial rate, as I mentioned, we are budgeting a no change in our commercial rate. And I think this slide is trying to convey that we've already recognized a -6.5% rate change because of what's going on in the current year. Next slide, Jay. And I think that this speaks to that. The first two rows of this are what I mentioned and why, a big part of why we're missing our budgeted margin this year is the Act 55 impact on our infusion business and the lack of lift from Blue Cross Blue Shield as originally budgeted. I don't know how it got past our quality control, but the total line there is off in that it should say total reductions already in FY26 and the total 3.3 million. So I'm sorry for that. But, this basically is, demonstrating the fact that through other means, we've already had an effective commercial rate decrease. The one thing I want to pause on is my comment at the bottom. And this is the other side of the coin of leaning into the affordability issue. Beyond reducing gross charges by 1% and doing something in the short term, as came up clearly in our working meetings with the critical access hospitals, the contractual arrangements with commercial payers in terms that are based on a percent of gross charge are really one of the biggest problems to overcome in reining in gross charges and transitioning to reference-based pricing. And so we are actively engaging our three largest commercial payers, MVP, Cigna, Blue Cross Blue Shield, to go into this negotiation process with the goal of eliminating percent of charge terms from our contracts. And if we are successful in doing that, that will completely uncouple how we are reimbursed from our gross charges. And I think that positions Porter really well to participate in, future affordability discussion. Yeah, so let me just say that, so keeping the benefit of keeping the rate change at no change is that as we go through those negotiations and change those terms, it'll be a much cleaner calculation to make sure that we actually came out the other side on equal terms. If within that reconciliation and calculation, you also have to built in an overall rate change, it makes it much more complicated. So it also, in my mind, supports the 0% commercial rate built into our budget, enables us to better do that work. Okay, commercial net patient revenue, as I mentioned, is basically coming in at the guidance of a -1%, largely driven by the volume increases that we have built in. And as you can see overall, the major commercial category of this payer breakdown, which represents the state of Vermont commercial payers that we negotiate with, is shrinking. And our Medicare population is growing. And I don't think that's a big surprise to anyone on the call, but I just wanted to point it out because we do see that playing out in our budget. In 26, both categories were about 41% of the total. And in this year's budget, our major commercial is down to 35 and Medicare up to 43. So an 8% spread between the two year over year. Next slide, Jay. So this really gets to the heart of some of the volume increases that we have built into the budgeted revenue. And again, none of this really is beyond expectations of what we already have. So the inpatient days, we have budgeted level with this year. We know we're under budget, but we have a plan to get back to our originally budgeted levels. ED visits continue a positive trend. I don't know if it's positive, but volumes continue to rise year over year. And, Bob spoke to that earlier. The worked RVUs from the medical group are increasing 2.9% budget to budget. That is, solely a product of the work already being done, does not include any built-in changes due to the A&M work. OR cases, again, a slight increase, 6% increase over what we originally budgeted this year. So not a huge year-to-year expectation change, but it is an expectation change from what we're currently realizing. And this is an active discussion with Porter leadership and medical group leadership and network leadership, as we all share the same physician group. GI endoscopy is going up significantly, but we actually have recruited an additional provider there. And so that's a reasonable expectation. The radiology modalities are largely built on run rate. MRI looks big, budget to budget, but again, that's the experience we're seeing this year. And infusion, again, we started purposely trying to move patients from the medical center to Porter, Addison County residents, and grow the infusion service at Porter. But the recent changes in the not really the cost structure, but the revenue attached to the business has really made us pause. And so our goal is to really maintain our current level of volume, which is a growth over prior year, but we need to find a way to do it at a lower cost. And then lab tests are budgeted at a current run rate. Next slide, Jay. Okay, this is a slide similar to what you've seen from the other partners about the A&M impact at each affiliate. So at Porter, about $1.36 million of expected savings. Some of that is happening today, and some of it is built into our FY27 budget and playing into why we are able to keep our overall budget flat, budget year to budget year. Budget expenses flat, budget year to budget year. Next slide. This is just a summary of rates assumptions built into the budget. We've already spoken about most of these. 0% change for commercial and Medicaid, a 3% pay increase from Medicare. Just to look at where our free care and bad debt percentages are as a percent of gross charges. Even with the gross charge decrease, we're expecting those rates to come down slightly. And we spoke a little bit about the gross charge reduction and why. So next slide. So expense growth. So budget year to budget year, Porter Hospital expenses overall are staying flat. A very slight reduction. And this is against the guidance of no more than a 2.4% growth. So recognizing this is an anomaly in the data that you've been receiving for budgets in FY27, let's get into how this is happening. So as I mentioned at the top of the presentation, there are adds and subtractions. Some of the things that are happening are increases that everyone is experiencing, and the box on the left really summarizes those inflation factors that are built into the budget and an increase in expenses year over year. So the top line is interesting in that, the reason why Porter Hospital is experiencing a decrease in our, let's say, provider salary rate is that the provider complement working or assigned at Porter for this upcoming fiscal year is more APP heavy than physician heavy. So that that tilt to APPs is starting to happen at Porter Hospital at least, and that's lowered the effective provider rate that the hospital has to pay. So that line should say provider salaries, because what we're seeing is it's more APPs than before. And again, that's lowering the cost of care for an increased level of volume. Where we're seeing some expense reductions that are offsetting those increases are in the box to the right. There is a reduction in depreciation in the P&L, but as I alluded to earlier, we're still looking for a way to rein in our costs related to infusion. So we do have budgeted on the pharmacy line alone a $1.6 million expense reduction. And we don't have a clear line of sight on how to achieve all of that. So, it'll be a conversation we have, I'm sure, throughout the year. But beyond that, and something to be proud of, honestly, is the work that we've done. Bob alluded to it with managing the workforce. And whether it's working with the network or combining forces with Elizabethtown, we've gained tremendous efficiencies in how we deliver care. And so we actually have a $900,000 reduction in overall salary expense budget year to budget year. And the major drivers of that are listed below. Continued traveler reduction. I do have that number here. Last year's budget had 19 travelers in it. This year's budget has 10. Staffing efficiencies and premium pay management. Just better management of the workforce, making sure we're, having the staff we need when we need them, but not when we don't need them. And lastly, the provider mix being more APP heavy than physician has lowered the effective, rate that we have to pay for those provider services in the hospital. Okay, in summary, this is it in numerical form. The first column is our current year budget, and at the bottom, you see that $10 million expected income. Just to the right is the forecasted 2.1, and to the right of that is the submitted budget back to a $12 million income. If you look at the total expense line right above that, again, budget year to budget year, it's basically flat. So the income improvement that we expect to see from where we are currently is on the revenue side of the equation and largely linked to volume increases. So the risks, I think, came out as we discussed them, but our average daily census at the hospital, needs to come up by 2 or 3 patients a day. And we're actively talking about how to make that happen. The OR volume needs to materialize. And I don't think it's not because there aren't cases to be done. We have to organize a way to get to them. And then maintain our current level of infusion services. There's a risk that we're not successful in controlling the cost in the way that we hope. And if that's the case, we'll really have to take a look at the mix of those infusion services, the types of patients we're taking care of. Within the revenue stream, our Medicare rate assumption is not a given. It's based on a cost report filing, which doesn't happen until the year is over. So, that's a thing that we're always, trying to model and stay ahead of. And then maintain our current level of reimbursement with our commercial payers through this, negotiation, which is clearly around the terms, not the rate. The idea is to get through the negotiation and just get percent of charge terms eliminated from where they exist. These contracts aren't entirely percent of charge based. I would say it's a quarter to a third of mostly outpatient services. But even there's work to do where, we can base those payment rates on something else. Ideally, going back to what Jessica Michelle was saying on Monday, it's something Medicare based where we can say and track and know that we're getting reimbursed at a certain percentage of Medicare. It allows us to participate. And again, that overall affordability conversation. On the cost side, our inflation increases that we have built in, hopefully they are adequate. The pharmacy cost containment is, part of the risk of maintaining the volume. Union negotiations are happening constantly. So many, almost our workforce is almost entirely unionized at this point, as is the case with most of the partners. And there is always a union who's up for negotiations. And we do our best when we put these budgets together to forecast, what those negotiations might require financially, but it's always an educated guess. And the staff and efficiency changes, some of those changes built in our FY27 budget that allow that salary line to actually decrease have not been executed on yet. We were well on our way, but some of them still need to take place. And until they happen, there's a risk they may not. This is our last slide, our closing statement, requesting your approval of our budget as submitted. And that's all I had.
That's a really helpful walkthrough. I appreciate that very much, Mr. Camus, and I hope you're doing well. And thank you, Mr. Wortmeyer. I'll open up to board questions, starting with Member Merman.
Great, thank you. Thanks for the presentation. I have a few questions for you. So one of the slides you put up had a lot of your hospital volume increases or changes, but one of the things that was in the narrative that wasn't on the slide was the medical group arrived visits, which on page 13 of the submission shows a reduction of 32%, but flat, slightly improving medical group RVUs. And I was wondering if you could help me understand the decrease in visits, especially in the context of the A&M report of trying to increase access with the flat RVUs.
Scott, would it be helpful if I jump in here?
Please do, Jen. Thank you.
Thank you. Thank you for the question. This was also one of the questions for in the RFI responses, so you should have a little bit more detail.
Okay.
Member Merman as well, but we do have a 2.9% RVU increase in the budget. And so we would expect a commensurate increase in our arrived visits. For full transparency, that is a lower budget than we should have submitted. We are just beginning to refine our processes for actually budgeting those arrived visits, and clearly identified an error that occurred with the budget submission for Porter. So we do expect to exceed that budgeted arrived visit number.
Sorry for missing that in the RFI, but I appreciate the clarification. So there's no services being reduced then associated with that?
That's correct.
Okay, great. On that same chart, and you brought this up earlier, I think one of you brought it up earlier, that the MRIs are increasing by about almost 30%. What's allowing the 30% increase, 28% increase in MRIs? Is it hiring more techs, opening up more hours?
Well, I can start, but I welcome my colleagues. But, improving access has been a concerted effort, especially in the imaging space across the network. So I know we have been expanding hours at Porter, and that's a part of it.
Yeah, I can add to that, Member Merman, too. If you look at kind of there's wait times at some of the other hospitals too that could be in excess of several weeks. At our smaller hospitals, we can maximize our space, our equipment, and often can get patients in much sooner than several weeks. So it's really coming down to maximizing our equipment and resources here, which is doing that.
Okay, so the capacity was there. Now you're rescheduling people who are getting it elsewhere.
Yeah, and I believe Scott had mentioned too that that was budgeted based on our current run rate. So it's not that we're anticipating building that volume. That's just currently what our run rate is right now. So we just want to maintain that.
Okay. I looked at the revenue worksheet, and if you take there's MRI revenue is carved out, and then the budgeted volume, and I just took did some simple division, and it looks like about just under 4,000, maybe 3,800 per MRI. Which is pretty high compared to Medicare pricing. If that was, reference price, that's a pretty high price. Did you reduce those MRI prices by 25% in this recent negotiation with Blue Cross, like UVM did?
No. Our goal going into our negotiation with Blue Cross Blue Shield was an overall 2.9% increase. And it ended in a 0% increase. So, our rates from Blue Cross Blue Shield stayed unchanged.
Okay. I guess one thing I worry about when I see this is relying on these increasing volume on these really high outlier price things like MRI driving your revenue. Do you have any concern about putting you at sort of risk for future budgets if, with all the discussion about especially imaging prices within the legislature this year and within reference-based pricing, trying to rationalize prices?
Yeah, I mean, obviously, I'm concerned, but that is largely why I'm focused on getting our reimbursement terms uncoupled from our charges, so that we can start to look at them separately. And it's a perverse incentive to increase your charges. And we've talked a lot about the impact that has on Medicare beneficiaries, but when your commercial payers are increasing their reimbursement based on how much you charge them, a lot of the hospitals are kind of stuck in the middle, and we heard that tension in those working meetings. And so in my mind, the sooner we can get reimbursed on terms that are not based on charges, then we'll be free to bring charges down as we need to again, lean into our affordability issue as a state. But right now we have reimbursement dollars linked to those charges. So every time we decrease them, we're going to decrease $1 in reimbursement. And once we break that, I feel we'll be much more ready to participate in those conversations.
I do want to highlight, I spent a lot of time looking into this Medicare cost sharing issue, and Porter Hospital actually has the lowest Medicare cost sharing of the critical access hospitals in Vermont. Still a pretty high number. I think it's like 35-ish%, but lower than our highest, which is 69%. So I do think that's important to call out. Okay, and then I think you also sort of addressed this a little bit, and I think this, I don't know what was discussed in the CVMC timeframe, but within the UVM hearing, we talked a little bit about the change from 32 to 36-hour clinical time for specialists. Does that have any impact at Porter, or are your specialty physicians already contracted differently?
I'll look to my medical group colleagues to jump in on that. I mean, we do share the same physicians, but.
Ramsey, do you want me to jump in?
No, I mean, we have specialists that are employed by the medical group that work at Porter, and those folks, if they're not at 36 hours, are moving to 36 hours per clinical FTE.
Okay. I just like, I had this sort of question earlier today too at UVM, but just so I understand the impact of Act 55 on your gross payer mix. I think you had the slide up that showed the various payers over time, different color vertical blocks. Is that what you'd use with the total height of the block? Is that and if you were to divide that proportionally, is that how you define payer mix based upon your net revenue, or do you define it based on your gross revenue, or which is our?
Yeah, those graphs were based on gross charges. and they, totaled to 100%, and they just broke down where all of the gross charges are going.
Okay, and so the change in payer mix, how much of that is explained by Act 55 and how much of that is explained by different people coming to the hospital?
None of the payer mix change is explained by Act 55. Act 55 is just, impacting the amount of revenue that we're receiving for commercial patients. The payer mix change is largely, I believe, a population phenomenon with the aging of the state. Commercial population is decreasing. We're not the only ones to see that as a hospital, and our Medicare population is increasing. So Act 55 is separate about how we get paid for that commercial population. I don't think it really drives how much of our payer mix it is. How much our population mix it is probably a more way of describing it.
Okay, yeah, I guess my question was if Act 55 is selectively reducing charges in certain areas, is that the use of those services and the reduction of charges, does that sort of play out into the total gross charges?
Yes, and we have to reduce our gross charges for everybody who comes through, for example, our infusion service. So commercial, Medicare, what have you.
Okay. When you were talking about your infusion services, I think you mentioned something about what services you should be providing as infusions. Can you expand on that a bit more? What did you mean by that?
Sure. There are types of diagnoses that you treat in your infusion service. For example, at Porter, we don't do chemotherapy. So that's not an infusion service that we offer. But outside of chemotherapy, there's a world of other, diagnoses and drugs that take place there. And this is about where my clinical knowledge drops off. But within that world, that's where there are options about how you, source the drug need. Things like biosimilars, other alternative, like there are ways of managing that complement of patients without changing the complement of patients. If it's determined that, the only way to be, keep your hospital afloat is to offer this set of infusion services instead of those sets, then that may be a place that we have to make some decisions. That's what I'm looking to.
I just want to augment that we do have an APP and a physician in HEMONC that are going to be providing services at Porter in FY27. And we're looking at potentially offering anti-cancer therapy at infusion there. But those plans aren't worked out yet. I'll say it's not a financial decision. It's a patient-centric decision point.
Okay. All right. So a couple questions there. So within trying to determine which services are available, is it that are you saying that some services could be provided at home, say by like an home injection or home infusion, and some services need to be provided at the infusion center? Or are you saying you're trying to determine which group of services that you will provide and which group of services you will drop?
From what I see, Member Merman, it's all of that, because we are actively trying to move to self and home administration where it makes sense and where it's possible. I know that is happening. We haven't gotten to the point of reviewing, each drug that we're infusing today and whether we should continue it or not, because we're, again, beginning to, closer case manage the patients. But between that and, the acquisition marketplace and legislative changes on the what we can charge for revenue, there's just so many moving parts. It's really hard to get a firm grip on, frankly, what specific service is profitable and which one's not. And this is the work ahead of us to try to figure it out.
So would there be a time where you feel like that you might have to say that you can't provide a medically necessary service there because of the profitability?
No, because we do a lot of things that aren't profitable, just like every hospital. So it would be, that decision would be made within the larger context of what's right for our patient population.
And then the one other question, Ramsey just mentioned about the oncologist. My recollection was that there was an independent oncologist in the Middlebury area who retired and that Porter was absorbing that oncology care. Did that not occur?
Jen, do you want to take that? Because I don't know the effort specifically.
I don't know, Ramsey, if I have that effort specifically either, just off the top of my head.
I'll have to go back.
Yeah, no, you are correct. Dr. Unger was that physician, and he's retiring. And he did do. Let's see, we did the infusions that we could do here. We haven't done yet any oncology or infusions. So those were done yet at the medical center.
And then I guess the last question I have that was from the presentation, you were talking about your contract pharmacy revenue going down. Is that business going to UVM or is that going elsewhere? And how do you know?
No, the business is going to, or it's staying with local retail pharmacies. They just no longer need to acquire their drugs at discounted prices through us. There are other ways for them to get them at those prices. And so without us being the provider, there's a dispensing fee that attached to that is no longer being generated. So it's really just a change of where the existing retail pharmacies are sourcing their drugs.
Is that just the maximum fair price drugs or are there other drugs involved too?
I can't speak to the universe of drugs involved, unfortunately.
All right. Thank you. That's all. That's all the questions I had. Thanks.
Thank you.
I just have a couple questions. I want to start on the Medicare cost sharing issue. And I want to make sure I understood the testimony correctly. Porter Hospital has no charges that are above 500% of Medicare?
None that I am aware of. It would be an extreme outlier.
I assume you looked then?
Yes.
Okay. And what efforts have been made to uncouple reimbursement from charges?
To date, none. To the extent that they've been persistent in our contracts year over year, none, as far as I'm aware of. That's why this is a new foray for us that I hope that, and we've gotten positive signals from our commercial payer colleagues that they want to participate in this work because they understand the value. So I hope that we'll get some positive synergy and get it done.
Okay, so you have had conversations with commercial payers about uncoupling reimbursement from charges?
Yes.
Without getting into specific detail as to particular payers, can you give me and the board an overview of those conversations?
Well, I haven't been personally involved. Members of our contracting team have. And at this point, it's really just a notice of the intent because the period for negotiations isn't quite here yet. But there's a lot of pre-work that we on both sides could and should do. So I know that there's an open dialogue. I can't tell you, how far or where they've left off.
So it's something I would like to see happen this contracting year. Is there any barriers in your mind to Porter's ability to execute on that this year?
No, as long as our payer partners are willing to meet us halfway.
Understood. And if you were to change it so that's not based on charges, the reimbursements, can you describe how you would determine the reimbursement levels?
It would depend on service in question. And, you know, as I mentioned earlier, I think I would prefer if they were somehow Medicare reference based, and, you know, that way a percent of Medicare conversation could happen around services. You know, for example, you know, an APC payment for a, you know, certain outpatient encounter versus a percent of charge. There are multiple alternatives out there. How far people are willing to bend, how far their systems can bend, like all of that kind of plays into, but I gotta believe that there's a first step that we can do to break. And then if it takes refinement in future contract cycles, that's great.
Yep. And at Porter, are there any mechanical or system holdups on your end to being able to contract as a percentage of Medicare?
Say that again, Chair Foster.
Well, sorry, so if it sounded like as if you're going to move off of a charge-based reimbursement, your
Right.
ideal scenario would be a Medicare-based reimbursement, which I